So I'm Doug Fritzman. I'm the head of government partnerships. I know some of these folks because I used to be at the Office of the National Coordinator, directing the Office of Standards and Interoperability. So I know a little bit about this particular topic, but we've got a whole host of experts, and we're going to start with Lisa, just to kind of give an introduction.
Yeah, hi everyone, Lisa Berry. I'm the CEO of Civitas Networks for Health, which is a national organization that represents nearly all of the regional and statewide HIEs across the country and regional health improvement collaboratives.
Hi, I'm Mickey Tripathi. I'm the National Coordinator for Health Information Technology in the Department of Health and Human Services.
Terry Cullen, Family Medicine Recovering Informatician. I was the CIO for Indian Health Service and Chief Medical Information Officer for the Veterans Health Administration, and now I run a very hyper-local public health department in Arizona.
John Bush, one hit wonder so far. Looking for another with Zus, which is kind of a Build-A-Bear studio for people who want to build their own tech, but don't want to build the whole stack.
Great. Now I can't get that out of my head. So we're going to start with the first question. The first question is, when you think about architecture, architecture tells us how to build buildings. City planning helps us design and build cities. Is interoperability a problem of architecture or city planning? Mickey, why don't you start?
Yeah, well, I mean, it's both, but I think that fundamentally it's about, sort of, I would think of city planning, public works, which is sewage and fiber optics, doing both of those, as well as, a little bit of zoning is, kind of how we're thinking about it, because the market's so fragmented. So you need to be able to lay that foundation, lay out the grid, lay out the, your utilities, lay out, sort of the roads, and then let the buildings get built on top of that.
Good. Lisa, do you want to?
Yeah, I think, so at Civitas in our community, we think a lot about data utilities. We're working on an evolving health data utility model that's built around data organizational governance. And so I would say I'm on the utility side. I really think it's about building out and planning how things work together in the cities.
Tara, you wanted to answer this
Yeah,
question.
I wanted to answer this because you may be aware Department of Transportation has on the streets, you may not be aware of this, a large Safe Street initiative. And so to me, when I read this question, I really thought of it's the on-ramp, it's the off-ramp, it's protecting the people on the edges, it's making there a speed lane to go right down the middle so people can go really fast and nobody gets left behind. So for me, it's planning. A little more than city, though.
I see how you could think that great cities come from architecture. And I see how you could think that great cities come from the planners. But I think, and I grew up in one of the great cities, New York City, the great cities come from food trucks and buskers and raves in abandoned buildings. It comes from the kooks who are excluded from the mainstream, who civilize the affordable and therefore nasty, dangerous parts of town and gentrify it in creative, unplanned ways. And with data, I feel like we're in a similar place where we're trying to push the string and said, are we really going to do a panel on interoperability in 2022?
I did say that.
And I think what I'm excited to see these days is the buskers and the raves, the new digital-first providers are starting to actually want it and use it selfishly, not comply with something.
Okay. So I guess after dinner tonight there is a rave. Is that what you're saying?
In Maine.
The Palm does not do raves.
Okay. I'm
The
just
Palms
Did you
is a city planning stake.
I'm just checking. So the next question. They say the future is here. It's just not evenly distributed. So Terry, give us an example of where the future is already here.
Oh, can I answer where it isn't here? That would be easier for me right now. I think where the future is here are things that I'm gonna, what you see is from where you sit. I'm sitting in public health right now. Immunization registries, interoperability is really working. Prescription drug monitoring, for any of you that are a prescribing physician, you've probably been told you have to use that every time, whether you wanted to do it or not. It may be integrated or not integrated, but you're probably hitting on it. So there are some real capable things that happened. HL7 transmission of labs after COVID started, for those of you who may recall, stacks and stacks of faxes at health departments. Now very, very few stacks. Even mom and pop labs have started figuring out how to do LOINC and HL7. What an amazing thing. So that's where we have it.
So where is it not working?
So where it's not working is actually in the public health space, in the rural space. We have to talk about equity, so I'm just going to talk about it, the equity and justice space. Lots of people are being left behind from interoperability for multiple reasons, including the way they're accessing the healthcare system. And so the vulnerable, I'm going to go back to my street. On the street, if you're on the side and you're not where a crosswalk is and you're trying to go across, you're going to really run a risk of getting slapped and spotted. And that's where I think we're leaving people behind.
Jonathan, you have to start with where it's not working.
The future is alive and well. Oh, really?
Yes, I totally messed you up.
Sorry.
Yeah. Well, to get it off, it's stuck here.
Okay, get it out.
The future is alive and well, and it's living in toast. We've all now gone to one food place and then go to the next food place, and all the shit moves over from one little tiny restaurant to another without a plan. The two restaurants don't even know each other, but it's passively transferred. The notion of ACTA in the corporate world has sort of made it passively into our lives in retail, where we use the system a lot, and so product-centric inventions can rise up. In healthcare, on any given day, 94% of us aren't sick, so we don't use it enough across enough players for that cross-connected layer to be born yet. But it's coming. We live it already. And where it's not working, I mean, shit, man.
The rave. It's definitely not working at the rave.
TEFTA is voluntary. It's the best thing in the world. The Cures Act of 2016? Not yet in use? 2016? Like, let's go. That idea that it takes so long and takes so much marvelously patient, judicious, kind,
Civil servants.
teeth-gritting, sweat, effort to get people to voluntarily, when they really kind of don't want to share data, participate. That's obviously tragic and frustrating and expensive and bad for every fancy word that we care about. So that's where it's not here yet.
Some people can't dance.
Faux show.
Yeah. Lisa.
I mean, I guess I think I would say the same thing about where it's working, right? We had a bunch of projects over the last couple of years where everybody got together really fast and said, oh my gosh, we don't have to do these barriers. We can play together. We have to do it. There's urgency. There's need. And so we saw those real improvements happen on the immunization side between IASs, between HIEs. Civitas works on a project with ASTO, IRA, and AIM to connect HIEs and states and IASs. There's also STAR HIE and some work around SANER, sort of getting those connections. Those things are working. They're starting to happen. But you see what's there is that there were people saying, I can't do it because my business model. It wasn't because they couldn't do it. It was because of their business model. And that's the problem. That's where it's not working still. So people are saying, we're not aligned. We're not saying, this has to happen no matter what. It is an urgent need across our country, across all these systems. That's the problem, is the business model is still the barrier to interoperability.
But can I plus one that? I feel like that is huge. We've got, everybody's FHIR compliant, but nobody uses FHIR natively, ever. In fact, I had a guy's like, oh, Zus is FHIR native. Why? He's trying to help me, like a guy who's maybe got a drinking problem. Like, why are you using that? The overhead is exhausting. It's not worth it. Like, well, if we all use it more, maybe it'll. But I think the fact of this new,
your excuses fly away when you're on the same, consensus-based platform that we've been working on for years and years and years across.
And when
the
your
smartest
business
people.
model doesn't have hoarding all of the data about someone as part of their profit stream,
That's the
right?
core thing.
If you're a narrowly focused national digital-first player, you can't harvest the mammography margins, right? If you're doing
Right.
early stage alcohol disorder like RIA or irritable bowel like OSHI, you need the data, you'll share the data, but you're going national, and all these kind of lovely institutions that occasionally act like trolls under the bridge, our health systems, have to share with you, but you selfishly want to, for profit. Evil Bill and Evil Ted want to be data sharers in these digital first national models. And I think that business model shift is huge.
Okay.
There you go.
Now, Mickey, bring us on home.
Yeah,
Where
bring
is
us
it
to
working?
reality, Mickey.
Where is it working and where is it not?
Yeah, so I don't disagree with, almost anything that Jonathan.
Mickey agrees. Tweet it.
That's why I'm in the middle.
And I'm at least as impatient as he is. And it is infuriating that the 21st Century Cures Act was passed in 2016 and we're still here, trying to get it done. But, we're spending a lot of time over the last year and a half putting all of that into place and saying the time is now. We're not going to wait anymore. In terms of, what's working, what's not working. I can give the example from sort of the same, sort of different aspects of the same example. Care Quality, nationwide interoperability network, they do 50 million transactions per day. If you compare that to, that's message transactions, provider for treatment purposes. The Swift Global Banking Network does 41 million per day, right? So already you're like, oh, wow, so healthcare is like, and that's just Care Quality. That's not what happens within Epic's Care Everywhere. It's not what happens within the Commonwealth Health Alliance, all that, right? So wow, you think about that, and it's like, wow, that's cool. That's a lot of records flowing. My mother broke her hip. She signed all the HIPAA forms, okay. But my mother broke her hip about 3 weeks ago. So I'm working with her at the hospital. One hospital's on Epic, one hospital's on Cerner. We're bringing her from the acute care hospital to the rehab hospital. They're printing out her records from the hospital, handing them to us so that we can bring them over to the rehab hospital. I'm looking at them like, you guys are freaking kidding me, aren't you? So anyway, right?
Do
Down
you
at the
know
bottom
who
of
I
food
Yeah, I
chain.
was going to say,
I don't know where I
You know
am.
who I am.
Down at the bottom of
I order you
I will
to.
tell you about the phone calls I was making and people contacting their vendor reps saying, do you know who's in the hospital right now? But right, so down at the bottom of the food chain, that's not working. So somehow we have a whole bunch of interoperability happening up here, but the people down at the bottom, you and me as patients and our providers, are still not experiencing that.
But that's implementation, right? That's what Civitas members and what our whole mission really is around, getting things into communities, the last mile, the last inch. And that's the issue, right? The workflow changes are so pervasive, they're so ingrained, like somebody will quote you all kinds of things that never had anything to do with HIPAA before they'll let you access your own records, right?
Right.
That's the issue.
So it's implementation, but it's also that business case at the end of the day, right? It's a hospital conveying down to the bottom of the food chain. We are interoperable first. All this stuff is electronic. We're not faxing anymore. We're not printing anymore. We're just sharing the information.
Default is
It's gonna follow
sharing.
that, right?
Yeah, you've got to
But I
get to
also
that.
think, I reminded Doug when he was at ONC and I was at HHS, we did a trip to a foreign country where we met with the people that had collected all the data. They got all the data. It was like, Doug and I both said, how the hell can this happen? And they go, we have a different culture than you. We believe in data sharing. And it was very, very insightful. There wasn't any, I can't share my data and this is why not. It was this sense that the collective mattered, that the public mattered, that the way you improve health status, and that was talked about earlier this morning, what we've lost 5 years of life expectancy now in the US, that you have to raise the whole ship, and you have to do it by making it not just interoperable data, but interoperable data that then gets used for a purpose of improving health status.
Do you remember my name tag?
And I don't.
They called me Dung Frisbee. Remember that? Anyway, that was a whole
Different
nother
memory for you than for
story.
Terry.
It was, yes.
That was another time.
I don't remember
That was the rave time that we didn't talk about.
So, Terry, you're going to start with this one. We talked a lot about cities and raves and roads, and what about the patient? What's the role of the
Yeah.
patient in driving interoperability?
Well, I think Mickey's example is great, right? The patient here, given that she signed all the HIPAA forms, we can talk about her. The patient is his mom. All his mom wants to do is get well. right? She wants to transfer to the appropriate facility. She wants to know that the people at the other end have the right care, that they have the information, that they can make the right decisions. So to me, the patient is at the center of this. Now, the issue, however, is the patient the person that drives the market that's gonna, who did you call it? Evil what and evil what?
Bill and Ted's Excellent
Yeah.
Adventure. You must have seen the movie.
If
Bill and Evil Bed take over the adventure.
Yeah, sorry, I forgot. But do they care about the patient? So the alignment, that value stream alignment is really important. But to me, at the end of this, for all of us, it's about we want our loved ones, the people we live in community with, everyone we care about to get better care.
Jonathan, where does the patient fit?
Well, I think the patient fits by voting with their feet or wheelchair, or walker. And that is harder in a sort of a vertical monopoly world where, hey, you can leave if you want, but I got the only otolaryngologist for 20 miles, I think that as care gets more digitized, the ability to grab 5 otolaryngologists, maybe that's a bad example, but certainly 5 oncologists, heme oncologists, from all over the country becomes much easier. Now it's easier for the patient. And remember, with patients, I think caregivers and loved ones are probably even more powerful from an information sharing pull perspective than the patients themselves. Can say, wait a minute, did we check with anyone? And when it becomes possible to check with someone in a click, when there are primary care players like Firefly that are national in scope and digital in nature, they can say, sure, here's 3 more, click, click, click. And the kids can talk to them without, pissing everyone off and rolling them out of, XYZ medical center, which creates huge trauma on everyone, including the medical center. I think that's a big, that business, it's another business model thing that's sort of quasi thanks to the pandemic, weirdly, that's going to help with that consumer agency.
Mickey.
Yeah, so I think the answer is that we don't fully know, but we're entering a whole new world here, and we want to be able to empower patients to be able to do what they want to be able to do. And we have, sort of a whole new approach for it as we enter this digital world. And I think that we want to open up all those opportunities. So, we can, and to Jonathan's point, the demand signal from the patient gets completely attenuated through the economics of healthcare, right? So we know that. So it's not going to be as responsive as, as gas prices or soap powder prices, and you don't have those kind of elasticities. But on the other hand, voting with their feet and providing them with the information to do what they want to do is what we're focused on. So we've got our information blocking rules. On October 6th of this year, the floodgates open a little bit from a regulatory perspective in that all providers, as well as health information networks, as well as EHR developers are required to allow the availability of all electronically accessible information in there that they're sort of the custodian of. That's not just structured data, not just sort of the smaller set of highly structured data that's been normalized and all of that. It's literally all electronically accessible information starting October 6th of this year. Do we know whether people even want to do that? A lot of people say consumers aren't going to be able to make sense of that. It's like a whole bunch of unstructured data and a whole bunch of deep narrative stuff and all of that. And it's like, yeah, that may be true, but why don't we let them decide? And why don't we let the market start to develop innovative solutions to provide solutions for patients? And if patients want to do that, they need to be afforded every opportunity.
Please.
I think that the sort of patients with chronic illnesses, with serious illnesses, are kind of been the canaries in the coal mine about this. They've been telling us for a long time how infuriating and awful and unfair and illegal and all of the things it is, the way that their information is being blocked. And at the same time, it's not fair to put the onus on them to solve this, them. And please, no one say we are all patients, because we're not all living with serious chronic illnesses and trying to deal with the pain and suffering of getting our data in addition to being ill and trying to get better. I think most patients just really want the data to go where they think it should go automatically. They expect that it moves like a banking transaction. And they're always surprised and really dismayed when they find out it doesn't. So I think that patients are not all the same. We are not all patients, and we should look at the lessons that those patients with serious chronic illnesses have been trying to tell us And then furthermore, from my perspective, from the health improvement area and the health information networks and exchanges, I really think we have to put patients inside those governance models to help decide what happens to their health data, because it's not fair to say that it's all there at the center and everything's around them. It's not. That's not how the business of healthcare and the business of healthcare data works. So I'm focused on how can we get patients into those governance models to have a real seat at the table to decide which use cases are appropriate for them and for other patients like them.
Good.
All of the above.
Can I say one thing about this? Because I think it affects both. So public health hat, blah, blah, blah. So the reality is, from a public health perspective, this is a very difficult conversation with patients and with consumers and with populations and communities. Why do you need to know that I got the monkeypox vaccine or that I have monkeypox? And so this whole other dialogue from a concentric circle about what does it mean when we really want to move to population health and public health and data accessibility and governance, there is a ripe field for a ton of innovation and to try to figure out how to accelerate that.
Totally.
Yeah, I think that's a good point. Jonathan,
Yes?
you've got a magic wand. It's scary, but
Yeah, really
you've got a
scary
magic wand,
Great.
for the whole
and you
place.
Please
can
don't
change-
pull it out.
and you can change one thing and only one thing in healthcare to improve interoperability. What do you change?
I think I give Mickey the power to make that which is voluntary required
Yes.
for anybody who receives federal payment. If you get paid by us, this is the deal. What we're buying is like the NOAA Weather Service. I don't want your app. I just want the feed.
Right.
And if you want our money, you got to give us the feed.
Okay.
That's my
Please
wand.
give him a wand.
Yeah. Mickey, you have a new wand. It's not here.
He's
What
like,
do you
I
change?
would give my wand
Right.
to Jonathan Bush.
Yeah, right, exactly.
You say-
I wish for 3 more wishes.
No, they
No, he said he can't say that.
No, I mean, well, so, it would be good for us to have better carrots and sticks to get people to do these things. But we're working really hard on things that we have. I guess if taking sort of a different tack, I would wave the wand and say we need to have just a much more aggressive approach to value-based purchasing across the board, because I think that's a big part of the business driver here. And we've been having our progression to value-based purchasing has been proceeding now for 10 years, and I'm not sure that the pace of it's even picking up. And I think that's sort of key to making a whole bunch of this work, is to make interoperability just a part of the business of delivering value at the end of the day.
Lisa.
I have a tie. Number one, I would eliminate
That's
prior
two.
authorization.
No, you
Oh,
can't have
come
two.
on.
You have to have one.
Okay,
Come
okay,
on,
okay.
Lisa.
Okay, all right. Any money that is spent by the federal government on Medicare or Medicaid has to come with interoperability and exchange. No more money goes unless you are adhering to the standards that we have all collectively begun to adopt, and some that are already for years and years have been adopted for exchange. No money goes. Medicare Advantage, Medicaid, managed care, whatever it is, you can't do it unless you're exchanging data in line with the law, which already exists, by the way. That's
That
it.
sounded like mine. Maybe we give her a second.
Right.
Yeah. No, it's Terry's turn. You've got the
Yeah,
magic wand.
so I, how long have we been doing this? Decades?
long
So
time.
I'm not sure that a regulation changes everything, so I'm going to give up on that magic wand. But what I do think is increasing understanding from a consumer, patient, population perspective about why this matters and how in the long run we raise this for everybody is what I would wish for. And the elimination of miscommunication on social media. Okay, so I got 2 things.
But
in
she
there.
just stuck
That's
two things.
I just,
Weird.
but I didn't offer 2, I just did
All right.
2.
Yeah, I saw that. I saw what you did there.
We should give Lori the other one, because now I can't. I'm dying to
Eliminate
know.
prior auth
Okay.
and make it illegal.
Oh, totally.
No.
Can I make RAF scoring illegal? The stars and the RAF, the whole game, the whole Jenga, to try to jack up your payments
Right.
by finding people to be sicker
Yeah.
by going through their charts.
Making people sicker.
Yeah. It's like,
Code stuffing.
go back and take care of them.
So we're getting close to the end here. So
We have
we're-
6 minutes.
Well-
We can see and you
We
can
didn't
see.
take over the asylum.
Well, with 6 minutes, let me
Sorry.
just add, just to connect some dots between what Lisa said and what
I've lost
Jonathan said.
control.
Just to sort of one incremental step forward, just so everyone knows, because it doesn't get wide attention because it's not rulemaking, it's an internal department policy, but we did publish a blog about this just 3 weeks ago, that there is now an internal policy within HHS that essentially directs the alignment of health IT activities across the department. And this has been something that ONC has been trying to do for a number of years, but the secretary just signed it, which is to say it's a requirement that all federal agencies, all HHS agencies, that's what we has authority over, are required in all of their funding mechanisms, to have standard-based approaches be the way that they start. And if they need, to do unique things because it's outside of the standards domain, all of that's fine. And the second thing is it directs ONC, my agency, to work with those agencies on their interoperability projects, on their health IT projects, to ensure as much alignment as possible with the standards that we're forcing the industry to adopt.
Are they giving you extra money to do that?
No.
Yeah. See, there you go.
But authority's a lot.
Something.
So you actually have a magic wand now,
We do.
okay?
So a magic wand.
Yeah,
It's not I don't know how you do it. It's like a small magic wand.
They have
huge,
to
Pixie
answer
does.
his emails,
Right.
which is something. They have to answer your emails.
Well, and it helps us have our purchasing power sort of multiply the effect of our, sort of regulatory authority.
Okay, numbers only, okay? It took the financial industry nearly 25 years to get to ubiquitous ATMs, and it's been 13 years since the first meaningful use regulation. How many years until we get the same level of functionality as an ATM? Lisa?
40.
40.
Just brought everyone down a little bit.
You're like intergenerational.
Totally.
Okay. Mickey?
I don't know how to answer that question. I'm going to pass on that. I don't know how
Pass,
to answer
okay. Terry?
Well, I was going to do a number and add a word, so 3 generations.
3 generations.
Yeah, because you can either have rapid generations or slow generations, but we're talking at least 40 years.
Okay. Jonathan?
7.5 years.
7.5.
Whoa.
5 years.
Okay. Let's keep
Let's
track
bring
of
you
that.
back,
All right.
and then,
2029.
If you have me
Were you
back,
guys-
7.5 years.
Okay.
I will pull up Mickey's chart and tell everyone
Can we
what
just
he's.
make a note of that? Make a note of that. Okay.
Great.
Okay, now we have 3 minutes, right?
3:16 for those of you who
Okay.
are counting.
So, blockchain. Jonathan, yes or no?
No!
No. No.
We can't do registration.
Terry?
Blank, no.
I'll modify my answer. I align with Terry.
You can't pass, you can only pass
No,
once.
I'm not passing. I'm saying no.
Oh.
No. Okay, you've heard it.
I'm not going to say anything different. Also, no. I echo Terry. Blank, no.
Okay.
I mean, so yes, we agree. There are elements of that
Yeah.
grandiose romantic concept, distributed governance, right?
Sure.
That I think are cool and that will find their way into, one of the things that Zus is working on is a you're fired button. Like, yeah, weird thing with HIPAA is like, you can't ever delete yourself from anywhere. So I think there are things like that, the distributed governance, like we could use in these new models, and I think they will show up. But there won't be like this magical Mr. Miyagi
I
somewhere.
separated magical wands and blockchain, if you notice.
Thank
Right.
you. Thank
I
you.
think that's right. I mean, there's certainly places where that ledger kind of technology
Right.
has some value within healthcare, but it is not, let's wipe the slate clean, start with blockchain, and everything will be great.
Okay,
Not going to happen.
we're gonna start with Jonathan again. Epic as a Q hen, good or bad?
Fine with me.
Hey.
They can be whatever they want. I think they're great. They did a great job, and their time has passed. And they won. I mean,
Yeah, they
she's
won.
amazing.
They won.
She crushed it. And she was customer focused, and she didn't push them into being what they didn't want to be, and they were grateful. And they literally used her to help them organize and enslave their doctors better. And not enslave, sorry, alignment their doctors. And it was a step forward, and maybe it was the best. It was in fact the best step forward we could have taken because it's the one we took. I think going forward, the data layer and the compute layer and the workflow layer will not be fused in titanium that is inescapable, because I think the new generation of customers won't want that.
Right.
Okay, Lisa,
I think that, is Lad Wiley
and
here?
not quite as long as that.
Is
Sorry, too long.
Is
We need
Lad
a
Wiley in the
soft spot.
room? Is Lad, okay, just saying. I think that Care Everywhere and Share Everywhere are a great place to focus. Haven't seen that really deliver as someone who was forced to use my chart with Johns Hopkins, hint, hint. Focus on what you're doing. Maybe let's find some way to break apart that market power. Sure, they can become a QHIN, absolutely great.
Carrie.
I say no, and the reason is because I think we have to disrupt what we believe is a QHIN and what it should do in the future. So from a quality perspective, so great foundational stuff, let's disrupt it as we're looking forward to what it means to do quality.
Okay, Nikki?
I think it's great.
Good.
I think it's fantastic. I think
No,
it's
I
fantastic.
like
The
that.
next gen's going to be a QN, wants to be a QN. I think it's fantastic. Commonwealth,
All
e-health
of them.
exchange, but I think it's
Want
awesome
to
that Epic
be.
wants to too.
Okay.
Well, they have to go through the people.
They have
We're
to apply.
done. You're at 0, babe.
So the
I don't know
last
what you're
question is a
doing.
one to the audience, okay? We have representatives for HIEs, boots on the ground providers, innovative new companies that are trying to be disruptive, and government, okay? By a show of hands, and I'm going to go over each one of them,
Who matters?
who's going to be the most important
Oh my
to
God.
solve the interoperability problem, okay? I'm going to start over
Do you
here.
get to clap for yourself?
HIEs. I'll come back if we have to.
Fine.
Okay?
It's all right.
Government.
Yeah.
Okay?
Democrats. Oh.
Okay, we're going to do you next. Okay. Innovative companies.
A few hands. All right.
Boots
We don't want
on
too
the
many, we
ground,
want to be
providers
special.
giving care.
I
Okay, I'm going to have to go back over here because
No,
nobody knew the equipment.
I already
HIEs?
clapped for her.
Oh gosh,
It's
terrible.
They don't believe it.
it's a three-way tie with a second place. That's all it is.
Great.
Understand.
Thank you, everybody.